I am so excited about our next session. Yesterday, we heard a little bit about Dan Fisher talking about peer-run respites. And this is a topic I know that many of us are very interested in and have a lot of questions about. So we are just thrilled to be welcoming Todd Noack, Executive Director of Life Connections Recovery Services of Iowa, to come up next on our conference stage to talk about how his team launched their peer respite and to give some insight on how they are building partnerships and blending strategies to expand sustainable peer-run programs. We're going to start with a brief video introduction to Rhonda's house and then jump right in.
We are at Rhonda's house. That's Iowa's first and only peer-run respite. In fact, it's the only one in the country that's in a rural area.
It's really good. So the respite house is a place, I like to call it my bed and breakfast for my emotional distress or life-changing, altering experience. The respite house is a place to go where, and again, all my staff are people with lived experience. And when I say that, they have some sort of mental health diagnosis or addiction issues. And who better to help, right? Because we've been there. We know what it's like. We know the resources. We know how to follow through the challenges of navigating the system.
So peer-run respite, peer meaning myself and all the staff included have their own mental health and or addiction issues and we're in recovery. So it's simply a place for anybody 18 and older who may be having some issues, mental health, addiction, or just needs support to come and do what they need to do. We are trained through the state to be able to share some of our story and kind of give hope when people may need it.
With drug addiction and mental illness, I've been on and off with it, but finally I've had enough and decided I needed some help, and I found this place, and it's actually one of the better places I found to stay at. It makes me realize that, that there's other people going through stuff like that, and I'm not alone. This place definitely gives you hope. I've met a lot of good people here.
I wish it was here when I was going to my recovery, because I sure would have came here. It's more relaxed. It's not, take your blood pressure or follow this rule or that rule. You work on yourself. You work on being you. We do a small screening to make sure that they're a good fit for Rhonda's house, to make sure they don't need a medical staff, because we don't offer that here. And then we let them know that we offer a 7-day stay. They have to bring their own food. If they can't, we have the referral center, and then they take care of themselves. They do what they want to do on their level and at their pace.
It helps them get that change of environment and revamp where it is they need to be. Some people may be living in an area where they don't get any sleep at all from neighbors or family. And if they come and they need to sleep, if that's part of the recovery, let them sleep, right? It re-energizes them to get back into life.
My recovery will always be going. It's an ongoing thing, but again, I'm surprised at how much I learn and how many days I've come in here feeling down myself and get hope from that person walking through the door. So, and then being able to be there for someone, I can give back. I got little letters behind my name because I had a mental health issue. To me, that was just an amazing thing in itself, to be recognized for that and have meaning behind all the things I've been through in my life. So to be able to come here and share that and to give back what I've been given it's unbelievable.
Call Your Life Iowa Crisis Line, 1-855-581-8111.
Well, good morning. I know you all have a lot of questions. I've spoke with some folks that have been in your area about opening peer-run respites, and I just want to share a little bit about how Rhonda's house got started. First of all, I want to really give a thank you to Dan Fisher, Mary Ellen Copeland, Matthew Federici, and the organizations they've been involved with. If they hadn't been here for Iowa, none of this that we do in Iowa would have ever existed. Dan Fisher came in and helped start the first peer-run organization, and I got to be a good part of that. And grew in my recovery through that organization, and doing many things from peer support training to now running Iowa's first and only peer-run respite house. So I'm going to share a little bit about how we got to where we are, what we did to get to where we are. And I'm going to share my screen here. And hopefully you all, Katie, do you see my PowerPoint? Okay, great. So I just real quick want to talk about a couple more things that we do. Besides the Rhonda's house, we also run an after hours wellness recovery center. I did that because I know a lot of people have resources during the day. It's the nighttime when things start breaking down and early warning signs start to arise that there's nothing out there. Through the wellness center, we also, through the pandemic, started a virtual recovery center. So when the recovery center is open, the virtual recovery center is open. And somebody, if they're home and they don't have transportation, they still want to take part in RAP or trauma groups or anything else, they can do that. I also employ the only 3 advanced level RAP facilitators in Iowa. And through that, we've trained over 140 facilitators in the last 2 years. Also, the Iowa Peer Workforce Collaborative, that is a state training that we have a subcontract with, where I do the state ethics, I support doing the supervisor training, and I have a staff, and that staff member's on here today, that helps with getting the word out and just sharing what the Peer Workforce Collaborative looks like, right? One of the problems that we have in the state, and I'll just real quick say it, is we have a problem with the reimbursement on Medicaid. We are one of the top states that, you know, the reimbursement, we talk about wanting to increase the peer workforce. Well, if we have a very low minimum reimbursement, how are the agencies supposed to do that? So that's a little bit about us, but we're here to talk about Rhonda's house today. And let's just say why it's called Rhonda's house. First of all, when we decided to open this and got to the point to open it, we had to come up with a name, right? We just didn't want to say, hey, the Peer Respite. Rhonda Schaus was a big advocate in the state of Iowa alongside me and others. And she was only 8 days older than me. She had 2 young daughters that are adults now that struggled with mental health. And me and Rhonda had a shared experience in a lot of things besides being close to the birth date. So it only seemed fit that on her passing in 2017, that we honor Rhonda. And so if you take the S away from the Rhondas and put it in front of the house, that's Rhonda's name. Rhonda's house is Rhonda Schaus. So it was really inspiring to be able to do that. So I'm talking about Peer-Run Respite. You know, again, I give credit to Dan Fisher coming in. And if you've ever seen Dan Fisher's video on Peer-Run Respite, there should be a Peer-Run Respite in every town. And he's not lying about that, right? Because we do have a crisis out there, folks. We've seen it, right? We've had anything from shootings in the last couple of weeks to other struggles, right? And a lot of things I think that we're doing is we're worrying about these crises, but we're not worrying about the healing of the crisis. And when we have a big cut in our arm and we put a Band-Aid on it, does it heal? Probably not. The Band-Aid will come off and we'll put another one on. And that's what our law enforcement's seeing. That's what our ERs are seeing. That's what our inpatients are seeing, right? And one of the things that we do in the Peer Respite is try to heal within. If we heal within, we might be able to support somebody in a way where they don't need to use that. And I have some success stories, and if we get to it, I'll share the success stories. But I want to tell you what got me on this venture. So I had a sole propriety, and I was doing the state peer support training. Me and another gentleman owned our own sole propriety, and I had contractors. And that was because the state didn't have the funding out for the training. We were doing it through agencies. Well, when the time came and the state released the RFP for the training, we decided not to apply. And unfortunately, the Iowa Advocates for Mental Health Recovery, which Dan Fisher helped start, just went away. And again, you know, we know the volunteerism part is a struggle. So I had to figure out, what am I going to do? And it was Dan Fisher. I had an email come across back in 2015 when everything ended about Peer Respite. Now I want to tell you, back in 2012, I was able to introduce at our state mental health conference the Kia House. And that's when Casey Moyer had come down and presented on it. So I had firsthand appearance of what a peer respite is. And then Dan Fisher. And so what I said to myself was, I'm going to start Iowa's first peer-run respite. And that was in 2015. Now I was thinking, how am I going to do this? I can't do it on my own. I can't do it as a sole proprietor. And I know the best way to do it is to become a nonprofit. So one of the things that I had to do was to build a board of directors. And if you've ever had struggles, a struggle is going on and trying to find somebody that has obviously the same mission, the vision, and passion as you, right? But I was able to do it. I was able to bring at least 3 people on, and we sat down and strategized on it. One of the other things that we had to do, we needed some technical assistance. Because we know what a peer-run respite is, doesn't mean that we know what happens underneath, right? All the screening parts, do we allow support animals? How many days stay, right? So we brought in the Kia House from Mental Health Nebraska, and they did a 2-day strategic planning with me, the respite house manager, and our board of directors. And we came up with some policies. We came up with some procedures. We then also reached out to SAMHSA for technical assistance, because we all know that SAMHSA does have the National Technical Assistance Centers. We were lucky and we were able to get help with our technical assistance through Doors to Wellbeing, an umbrella of the Copeland Center. So through there, what did they do for us? Well, we know, what do you have? If you want a house, you also have to have funding to run the house. So they came in and we were starting to work on the fundraising and the strategy of grants. We were able to get some free grant consultation in writing through a really good organization, Green Seeds, out of Pennsylvania, well, Philadelphia. And we were able to secure some grants. So again, this can be a book, and I've been told to maybe do this in a book. What comes first, the chicken or the egg? Well, what comes first? Do we get the house or do we get the money and then a house? Well, there's a lot of procedures too when you're wanting to do something like this. You have to get in your city the right zoning, right? And you may come across some stigma with a city, right, that doesn't understand this, and all they hear is about shootings and other things going on, and how dangerous people with mental health are, right? And again, somebody without mental health issues can be dangerous, right? And that's the thing you got to advocate for. Well, when we went after the zoning, one of the things they said is we needed to be in a commercial zone. And as much as we advocated for that, that didn't change, and it still hasn't changed today. So I am one person that's never afraid to ask for anything. And our grant writer that's been doing it for 30 years said he's never encountered somebody like myself, which I'm sure there's somebody else out there like me. But I went to our local hospital. See, we're in a town of 5,000 people, and we have a small hospital. Well, that hospital owns 3 houses behind the ER. So I went to the hospital and I said, hey, this is what we need. You know, you see a lot of people coming in here. We want you to let us use one of your houses for a couple of years to show that this works. After many meetings with me, the board of directors, and even meetings with the Kia House, they decided to go ahead and let us use one of the houses. Besides that, they said, we're going to remodel it for you to fit what you need. We're going to make sure it's up to code, up to standard, so that you have a good house. So we worked together on that with contractors. So I figured, okay, well, we made it through the Genesis Dewitt Hospital. Let's go to the Genesis Philanthropy. So my grant writer and myself worked with Genesis Philanthropy Hospital because it is a big hospital in the Quad City area, covers major county of Iowa. And we were able to secure startup money through Genesis Philanthropy. We also went to the region, our 5-county region, and we said, hey, we want to get some money to start up this peer respite. So they did that. So we secured the house. We secured some strategic planning in the operations of the house through Doors to Wellbeing and Mental Health Nebraska. And we secured startup money through the Genesis Philanthropy Hospital and through our mental health region. So startup is good, but you have to keep going, right? So we kept going. We got some grants. We got some grants from utility companies here. We got some grants through major foundations. One of the things that I've been doing, and it is starting to happen more, is I've went to our MCOs and I said, hey, why is it that we have somebody coming through the respite house and we are doing an evidence-based practice and we are not a clinical organization, but yet you will not honor that card and reimburse us for the person being there, and the tax dollars have to be spent. I don't think that a taxpayer would appreciate knowing that they're paying extra money when you could be reimbursing us. So we are in really good conversations right now with our MCOs and Iowa Medicaid Enterprise to be able to start to become either contracted or reimbursed on a daily rate for people coming into the respite house. And again, this is not just something that happened overnight. This is something that's happened all the way since probably 2010. But this is a start. The other piece of it is through the sustainability is our mental health block grant. No peer-run organizations were getting any money. 70% of the money went to community mental health centers. And my question when I went to the state, along with a couple other leaders and advocating, why do the community mental health centers get Medicaid, private insurance, Medicare, SAMHSA dollars, and other grants, and then you give them 70% of the state block grant dollars, when the peer-run organizations in Iowa don't get anything? Well, some really good things happened this year. The end of last year, a grant came out for 4 peer-run organizations to apply for funding. And we were able to secure through the state $300,000 the first year and $200,000 going on to be able to serve people in the entire state of Iowa. Now you would think too, when the region, I want to go back a minute. So we got the startup money through the region. They seen how much of a difference we were making, the impact, right? 2019, we had a person that came in that used the inpatient 9 times. And she came in January of 2020. And ever since coming there, has not had to use the hospital anymore, right? And thanks us a lot. But what I know is it's not us. It's a part of us, but it's mostly that person doing the things they needed to do and asking for them resources that we were able to support them with. Yes, it's my staff, it's my house manager, but mostly you got to start with the person, and that person should be commended for taking responsibility in doing these things, utilizing the RAP that we went through with them, utilizing other tools that we went through with them, and also having the availability when they leave the house to call us for support, right? So again, we can't stay on the phone for 2 hours with them, but the availability of making a phone call, knowing that person's there, knowing that person has a lived experience and understands what you're going through. So through that, the region had contracted with us in 2019 to do the service. So through that contract though, the problem was that we were only receiving 50% of the money. And when you have a budget of $300,000 and then you only get 150, it's still hard to keep it going. So now I'm going back to the state. That advocacy has finally paid out. Now we have a grant of $200,000 a year with 150 from our region. And now we are fully sustainable. And now is the time to bring in the MCOs and say, hey, they're not going to probably do this forever. We need to figure something out. But again, when you're starting this, it's what am I going to come up with first, the house or the money? And again, not being afraid to ask for anything. right? And showing your passion, showing your drive. And I'm going to tell you, from 2015, when I had this idea, until October of 2018, when the house first opened, there was 4 times that I almost gave up. But I always refer back to what I tell myself, and I try to tell others. If I say I'm going to do something, I'm going to do it. And I know Alan Green with Mental Health Nebraska, when I went to him in 2015 asking for the support, he said something I already knew. They came in Iowa a couple of years prior, and they tried to support an organization that was not peer-run to open up Iowa's first peer-run respite. And his words were to me, I already came in. I really don't want to come in again and not have it succeed. And I said, you are talking to a man that if I say I'm going to do something, I'm going to do it. And now we look at where we are today. So you may ask some questions on what a peer-run respite is. It is a voluntary short-term residential program. And again, it is designed to support that individual where they are. We've been talking about that the last 2 days, right? We have to support them where they are. If they're coming in and they do need sleep, we need to let them sleep. Who are we to say what the recovery looks like, right? So we've served over 285 guests since October 2018. Many, many inspirational outcomes. I know one person that utilizes our number quite a bit that stayed at the house already and now calls us. And do you know what that person would have done in the past? That person would have called 911. They would have ended up in the ER and maybe an inpatient unit, otherwise sent home. And that's what that person utilized before, was 911. We should not have to be utilizing 911. And I really do hope that the 988 number is a success. And it is given handoffs to warm lines, to peer-run respites, to recovery centers, because that's where it needs to start, right? If I'm going to go up my stairs, why do I want to start at number 11 stair, where that's the higher level of care? Why can't I start at the bottom and start healing myself within? And maybe, just maybe, I don't even have to use an inpatient, right? But we need to tell people about these peer-run respites. We do need to open more peer-run respites. Right now, I know when I started, Wisconsin's doing wonderful work. When I opened Rhonda's house, there was 3 peer-run respites. There are 6 in that state now. And what I really give the message to my state leaders, to my MHDS state leaders, is this: you may not care if the Hawkeyes get beat by Wisconsin, but when it comes to mental health, are you gonna let them outdo us, right? And that's what it really needs to be, right? You need to inspire people like that, state leaders, people that are gonna be funders, to give that real story, to give that example, right? So again, I do have many, many stories. I do wanna make this a little bit more questions. I can ask questions, but I do wanna just go through couple more slides. So how do I refer somebody to Rhonda's house? Well, number one, we have confidentiality, and we will not tell people who's there unless somebody signs off. And even if somebody signs a release that, yeah, my mom can call for me, if mom does call, we'll still not confirm or deny, but we will take a message. And then if that person wants that message, they'll get it. But they would call the house. We want them to call first. And here's the big piece, right? I don't want the ER nurse or the inpatient nurse or the deputy or even the therapist or anybody else to be calling the house and say, hey, and it's happened, I've got somebody here that would be good for you. No, it has to be the person. We have to talk to the person. Number one, we have to talk to the person to see where they are. If it's a person that's got a plan to commit suicide, even if they're sitting in the ER, we're not going to take them. But we will give them other resources. We might have them call an access center. We might have them call the crisis stabilization center, things like that. So after we talk to the person, there are a few other things. Well, one, I want to look at number 2 here. They can also do a registration online. Some people are a little nervous making a call, and I'll get to that part too, coming to the house. but they're a little nervous making the call. So what we do is we also have that you can make a reservation online. And when they do that reservation, my respite house manager will get the email and they'll call them back. And sometimes people would prefer to have you call them. So the guest must be 18, 18 and above. We have had people call for younger, and unfortunately, that's a huge problem, I think, a lot of places, but there are a lot of good states that are doing things with youth. But again, they must be 18 because we can't serve minors. The guest must be substance free for 24 hours. So when we're talking about that, if they say, yeah, you know, this morning, last night, I had 2 beers, that's different, right? So we just want to make sure that we're not getting somebody that's coming off some hard drugs or a long night of drinking or anything like that. And I'm going to be honest with you and say that we have had people call when they're intoxicated, and we told them you have to be substance free for 24 hours. And 24 hours later, they do call. And they took that responsibility to become that way so that they can get what it is they need. They administer their own medication. When they come in, they get a key to their room and they get a key to a lockbox, and they can put their personal belongings in there and their medication in there, but they're responsible for that. We've had guests that have come in and they say, I'm not very good at managing my meds, and I just want to feel safe. Can you lock them up? And we will lock them up, but it's their responsibility to come and say, hey, can you get my meds out so I can take my meds? Guests are also given a day pass if they want to the fitness center. That was one of my biggest pieces of my recovery. I went through being taken off work and having 3 back surgeries. And for me, going to the fitness center was really a calming meditation experience. And also what it did is it helped me make connections. I have a lot of older people that really enjoy me coming and having a good time. And that makes me feel good too. Guests, if they come, and we've had people come straight out of jail. We've had people come from the police being at their house or coming straight out of the ER or inpatient. They don't have any food. We have a referral center that is a food bank. They assist with utilities. They have clothing. So if somebody comes without food, we've made a good relationship with them that they can get some food to last them for 7 days. Guests are free to come and go as they want until 10 p.m. At 10 p.m., we want to lock the doors for security. We want to lock the doors so that people that are trying to sleep overnight, let them sleep. I do want to say that also, if guests have a job and they want to continue to go to their job, they can go to their job. That's not a problem. So if they do work overnight or they get off at 11 or 12, that's fine. We understand that. Guests must be able to care for themselves and bring their own food and medications that I discussed. But caring for themselves is, I'll give you an example. We had a person call that had 2 amputees and no prosthetics. And we said, are you able to care for yourself, bathe and other things? And yes, they were. And we had a shower chair, so they were able to take care of themselves. And that was really cool. That was really awesome. And again, 100% Peer-Run. Over 51% of my board of directors are people with lived experience. I am, and all of my staff are people with lived experience. Now, we don't all have the same experience, but we don't need the same experience, right? It's what works, what works. And here's what I like to say when I'm doing an interview. I'm not looking for you to have what I have, and I'm not looking to have what you have. But here's what I'm looking. I know we've all had the same feelings. I know we all had the same emotions when we've gone through what we've gone through. And there's no charge to the individual. We've had people that called and said, hey, how much is it per day? Something like that. There is no charge to the individual. And I can tell you this, that most of the individuals that come, they want to give back. We've had a lot of them that help the staff clean. You know, they have to clean up after themselves, but maybe the staff's going to vacuum and say, oh, let me do that. I want to give back, right? We've had some that have donated food for the next guest. And that's an inspiration, right? Because they care. And that truly is. Who benefits from this? My staff benefits from it, and the people benefit from it. So now what I want to show you is, now that we've embarked on a lot of things, I've talked about how you can start maybe go to your hospital and say, hey, do you own a house? Maybe we can work together on this. Started talking about the funding and where some of that funding comes from. Well, we came and embarked on a situation that happened this year. We knew was going to come happen. The hospital needed their house back. So last October, I invited the director of MHDS and mental health, and the mental health, disability services, and public health to come and visit our services. She also brought the deputy director and a couple senators. And she was supposed to stay an hour and a half and stayed there over 4 hours and went through a good box of Kleenex and talked with staff, talked with the guest. And then at the end, I did what I always do with a lot of people when I do a presentation or I'm talking about it. So now that you've heard it, now that you've seen it, now that you've felt it, did you feel called to write a check for $100 today or $1,000 today? And I told her I was just joking. And truly, I was joking about that, but I had a bigger thing to bring to her. I said, well, Rhonda's house has to make a decision. We have until June of 2022 to find a new location. How can you help? So they had discussions with our region, and our region put out a grant for capital expenditures. There was a big, not argument, but a big political piece that took about 5 months, but we did it. And we got a grant to purchase a new house and went to our bank and got a small loan to cover the rest. And now I'm about to show you the permanent location of Rhonda's house. That's the front of the house. The thing that came with it was an office building you see in the bottom right. That is our new main office where I'm at today. I was always, for the last few years, in the back of our recovery centers, wherever the locations were. And the other piece that came,
David and I, there we go.
the other piece that came with it, as you see in the bottom left corner, is that strip of white building is a motel. Now we're selling the motel. We had plans for it, but we don't see or want to embark on that yet because we do know there is a situation with homeless people that do want to move into recovery, but we're selling the motel. So you can see Rhonda's house. In the back, there is in the bottom right corner, a gate and a big patio area where now they can smoke right outside the back. On the side of the house in the top left corner, you see a nice patio area that if they don't want to smoke, they can go there. And you see the front of the house, and it's really nice. It's in the right commercial zoning, and we got a good deal on it. And now we have gone from a 3-bedroom slab house to a 5-bedroom, 2.5 bath. And my staff love that because they have their own bathroom. And I love the fact that we're able to now serve 5 people. That really warms my heart. Now, do I think it could ever be full? Yes. The respite house, when we were at the 3-bedroom, there was many times that we were full. There'll be times where we might not be full, and that's okay. You know, we just keep doing presentations, keep going out, letting people know about what it is we do. And I'm going to stop there and see if Katie has any questions for me or to lead into any questions. I know we have some time left, and I am definitely able to answer a lot of questions.
Oh, Todd, this was wonderful. Thank you so much. I would say, folks, put your questions in the chat. We'll pull them out. But I did see a comment earlier that it's so helpful for you to talk about like the big picture, you know, things about zoning or, you know, political will and working with a regional, like a regional system, but also all the way down to the fact that that folks call first, that you want to talk to a person, that you have online reservations. So I think you're preaching to the choir about the idea of peer respite, and the question, like you said, is how. You know, what do you do in what order? What do you need to be thoughtful of? So I see that there were a couple of questions in the chat that came around the idea of, lots of folks, I mean, obviously we're all coming from our own backgrounds, and we know that depending on the color of your skin, the language you speak, who you love, what your pronouns are, what experiences you've gone through, that that when folks from very different backgrounds maybe are coming together and staying together, that there can be misunderstandings or conflicts. And so there was a couple questions about how do you support a healing, comforting environment if and when conflicts do arise. Can you speak to that?
Yeah, absolutely. And conflicts have arisen between guests. I'm just thinking of one in particular, religion, right? And that actually is a situation where a person, talked very highly of their religion, and the other person couldn't see that right now, right? And they shouldn't. And again, there is a guest agreement, and part of that is talking about no politics, no religion, that you will care for each other. There's many things in that guest agreement that they have to follow, and we make sure to put the guest agreement on the wall in the bedrooms so that they know and remember the guest agreement. And there have been people that have had to be removed because of breaking the guest agreement. There's been people that have gone out and they did get intoxicated and came back. And again, that could be a big conflict if you have somebody in there that's trying to work on their sobriety and somebody comes back. So we make sure that we handle that situation right away. So we have somebody that's on call that can come and help take care of that situation, so that when that staff is working with that individual, the other guests are taken care of. There's situations, I know my respite house manager has said before, that never say that'll happen, right? And one of the things I seen in the chat was, what about sex? Can they have sex? 100% no. I mean, no. If we found that was happening, that guest would have broken the guest agreement. That is part of it in there too, that physically touching, mentally touching, that's all part of the guest agreement. We've even had where couples have called and they both wanted to come. Unfortunately, in that situation, they wouldn't be able to room together. They'd have separate rooms, and they would have to abide by the guest agreement as that. Staff has had their own family come, and the staff had to share with that family that, when you're here, I'm working with you as an individual that is in recovery. I'm not working with you as my son or my sister or anything like that. And they really watch their ethics, right? That's one of the big things. We do require all of our staff to be certified by the Iowa Board of Certification, because we uphold that high standard of, the professionalism.
I see a lot of heads nodding and thoughtful, a lot of people like digesting what you're saying. Could we also continue on that to get more into to kind of what your policies are around substance use, and thinking about a harm reduction approach, thinking about medication assisted treatment, and if you can talk about how either in your strategic planning or right now with staff, and especially as you're expanding beds and hopefully more and more folks will be using the respite, can you talk about what some of the considerations are that you've gone through in thinking about how you understand substance use in the context of recovery and respite?
Yeah, so I do know, a little bit of that is talked about in our internal training, but also in the state training. Again, we try to get them to as many trainings as possible. We give them that choice, that option. I'm thinking of one in particular person that went through the peer support training, but also went through the peer recovery coach training. And as far as us, we tried to make sure that we go through them trainings as well, so we know it. But coming up with that policy, like you said, about using, that can really affect the trauma of another person that's in that house. So having that planning, sitting down and going through that planning on who comes first. I'm maybe 2 minutes from the house, so if a situation arises, I can get a call, but we have a backup person that would come. And again, like I said, would take that person in downstairs and try to handle that situation, but going through some of them feelings and emotions that somebody's going through that witnessed that, right? So if somebody did come back and was intoxicated, for goodness sakes, we've had people come in and we didn't know it, but together, yes, they were using, and had 2 people that had to leave. It's really meeting them where they are and letting them know the effects of trauma and going through what the definition of recovery looks like through SAMHSA, right? Some of that extra training that we can get, any of that extra training we can get, we go through. I'm not sure if that answered your question. Oh, I do want to say one of the folks that I have works at a MAC clinic, and that is the backup person too. Goes to the MAC clinic under a contract that we have and works with individuals, because I know, because I had to go through that, the effects of what that feels like when you're taking all that medication to try to come off things. It's very debilitating. It's depressing. You get a lot of feelings through that. And so that person is the person that's our backup call.
I see some comments of, of also thinking about, I think around values and ethics, about making sure that those, that the house, is very upfront about welcoming all people, like people of all backgrounds, of all orientations, creeds, mottos, national origin. So I'm wondering, would you be willing to share your statement, like that you have to residents, so that we can pass that out? And do you specifically articulate an affirmation of being open to LGBTQIA folks, of folks all over the gender spectrum, of people who are coming with different backgrounds?
Yeah, absolutely. And I will share that. One of the things that I'm glad you brought that up, because that is a really good point you made about the identity, right? We actually had a person that we went and picked up. It was about an hour away. And this person talked to one of the staff that did the screening. And then when the other person went to pick that person up, they called the staff and said, "Hey, I'm on my way back," and said, "I just want you to know that this is not how they identify themselves. They identify as this." And unfortunately, that person did not identify as that. So we had a really good discussion at our next meeting about that. We let the person identify themselves, not us. We're not here to, really identify what it is. We can't make that decision. That is them. Now, do we ask how they want to identify themselves? Yes. And we do a demographics. And there are people that come in and say, I want to be referred to as this, right? And they get upset because their name is not that, their identity is not that. Them are all things that we go through. And our mission at Rhonda's house, again, is to provide that safe and welcoming environment that offers that opportunity for individuals that are going through that emotional distress to crisis, and change through the support of others with lived experience. And we ultimately believe that we're going to be there to listen for the untold story. We believe everyone has something to give, and we are grateful for what we receive as well. And we express that to them. And we also expressed about believing in the mutuality of that relationship, and we'll recognize that dignity and the worth of a person. We also have opportunities for that connection, both in our home as well as in our community. And our community, I can tell you, has been a big supporter. I've had an eye doctor call the respite house about a situation with somebody that is a relative. And again, that identity is huge. And if we miss that, because we are human, we discuss that in our staff meeting, and we have a staff meeting every Monday. And we pick Monday because a lot of things can happen over the weekend, right? But we also want to make sure that we communicate with the compassion and listen to what that person's going through, and sharing the boundaries of the person. I think back of a person that there was 3 young ladies staying at the respite house, and I got a call on a Sunday, and I went over there because one of the people were really struggling with that fact that the other person wasn't picking up after themselves, leave their slippers in the bathroom, would leave this here. So I went over and I listened and I said, here's what I'm hearing you say. And then after that, I said, I just want to show you an example, because I struggle with the way things are. I have to have everything in a place. And I said, what would happen if I throw this paper down on the ground? What could you do? Right? And just giving some examples of what I could do. You could leave it there, or you could pick it up. But again, we can only control ourselves, right? And that's the kind of thing that we really work with. All the staff is good at working with something like that.
It sounds like very much that you are fully seeing every person, every situation. I imagine too, you know, folks who have come to the house multiple times, remembering that this time is different. You know, every time is different. Every person is different. And I think that it's goes into the importance of keeping the house, I don't want to say small, and it's very exciting that you're expanding, right, to be able to work with more people. But I think as we look at in Maryland, what are the options? There's that piece of balancing how many folks can you support, and how do you create, you know, good support, welcoming, truly like person-centered, individualized. And so having the space and the time to do that, to be with each person and meet them where they are, and appreciate that staff also, like I love you said, we're all human. I know in our anti-stigma project, we talk a lot about how stigma is the matrix. Everybody has been stigmatized and has stigmatized others, and having space and trust for conversations about that so that we learn and grow. I want to pull 1 or 2 more questions out, sort of about the like on the ground, you know, procedures and processes. And then I also saw some questions about funding and thinking really about insurance and maybe clarifying that, and also questions about data and how you prove what you're doing works. So in terms of the very specifics, you mentioned at the top, and we'll make the slides available to folks, but you mentioned about kind of doing a screening for folks who about, I guess, kind of the intensity of a crisis that someone might be going through, but also about medical concerns. Could you be a little more detailed about that? You know, thinking about folks who maybe do have other health conditions, and really feel that a respite would be the right kind of support for them in that moment.
Yeah, absolutely. You know, we've had a person call, and I've been waiting for this, to be honest with you. A person call that has is confined to a wheelchair and has a movement issue, and has to have people support that person to, you know, get dressed, get in bed, get in the wheelchair, all them things, cook, even to eat. And that person, I ended up having somebody at the house that did call and needed to stay. So one of the things, and obviously the new house doesn't have it yet, but it's getting it next month, is a ramp, right? You got to think about the ADA guidelines, making it accessible to all. Because when we say care for ourselves, what does that mean, right? If I've got a caregiver, a visiting nurse that comes in and takes care of me, does that mean that I could stay at Rhonda's house? Absolutely. We would have that caregiver, though, obviously sign, and that's one of the things we would talk about in the screening, is that caregiver would have to sign a confidentiality form when they come in to support that individual, right? Because they're going to probably see other people there, and whatever they see, who they see. I love what Dan Fisher says, and started this in Iowa too. What's said here stays here. Who's here stays here, right? Nothing about us without us. And that's what we basically go through. So there are people that have called that maybe they are having too extreme of a physical issue that we have not accepted. And I can think of one where it was more of a psychosis that was extreme. So that person we didn't accept because we're not trained to do that, but we would refer them to the crisis stabilization and also help them by, if they need us to stay on the phone, make the call, we make a 3-way call, right? Whatever it is that we need from them. Even mobile crisis. We've had a lot of people from mobile crisis come, and mobile crisis is really good at knowing what our guest agreement is. They've seen that, they know what the screening looks like. So they know if that person might be a good fit or not. And they trust us too, right? Building that relationship with the community and the providers that they already know it's not probably a good fit, or they accept the fact that we say it's not a good fit, right? I don't know if that answered your question, Katie.
I think it goes a lot to one of the things that came up in a panel yesterday was, especially when in a leadership role and there's the vision that we are all working toward, and then there's the reality of what can I do today, what can I do within the boundaries of where I am, of what resources I have, of what skills and training I have. When we talk a lot about the professionalization of peer support, there's that thought too of having clear expectations all the way around is protective to everyone. It makes sure that we all appreciate and respect each other's boundaries. And that's part of self-care, is knowing when a situation is beyond how you feel comfortable or have the skills or knowledge yet, or even just are in the place to support today. And that part of growing all of these partnerships, I hear you talk about mobile crisis with the hospital, with area providers, word of mouth at the MAT clinic, of having a mutual understanding that there's a whole network of support. And then for every particular situation, kind of what's the right combo, and making sure that the person seeking support is at the center, that they're choosing, what's going to best meet their needs. I do want to ask maybe, and this is a way to slide into some bigger picture questions. If we talk about, proving that it works and justifying a budget, you were saying, some days your organization, the house is full. I imagine some days nobody's there, but every day you got to pay staff and keep the lights on and, do all that. So can you talk a little bit about what strategies you've used to collect data in a way that isn't disempowering or clinical, but that gives you the metrics you need to talk to funders, to go for grants, to sustain that funding?
Yeah, absolutely. So we have a mid-stay obviously the wellness vision, when they first come in, is a big piece. We meet them where they are. We know some of the situation, right? And in the wellness vision, we ask them, what are your hopes and dreams in staying here? What are your hopes and dreams for the next year, right? And that's what we work on with the individual, is that wellness vision. Now, I was talking about making a phone call versus getting on the website and doing application online. That's one of the other things too. Peer Respite in Iowa, the first one, people are nervous. They don't know what it is. What is this place? They're used to maybe going to a clinical place and not sure exactly what that is. So what we do is, we know the first day and a half, the person is going to be a little nervous, of course. So what we do is, usually about 3 days, we would go and we would do a mid-stay survey. And in that mid-stay survey, we want to know, what did you get out of your stay at Rhonda's house? What has been the most beneficial? And where would you have gone if Rhonda's house was not an option? And do you prefer respite, or would you prefer the alternative? And then, what do you think were the most beneficial resources utilized while you were here at Rhonda's house? And is there anything else that you would like to share while you're here with your stay at Rhonda's house? And then what we have also is at the end, a departure survey. So at the departure survey, that is something that we have, is it based on a scale? So not helpful, slightly helpful. And these are all tools that we've got from between the Wisconsin Respite, Iris House, and through the Kia House. But having privacy, is having privacy very helpful, or is it not so helpful, or neither, or fairly, or slightly? Freedom to stay connected to work, at school, friends, my family, and other places. Connecting with people who had similar experiences, was that very helpful or similar, or was it slightly helpful? But also receiving information on new ways to cope and handle stress and demands of life, and attending to self-care needs such as catching up on my sleep, eating, things like that. So again, we have a mid-stay survey, a departure survey, the demographics, and them are all pieces that help us with the funders, and not just with the funders. One of the things, like I said, when Director Garcia came, we could talk about the money it saves, right? In Iowa, it cost about $430 average in our budget per day to stay at the respite house. It cost about $2,000 at the inpatient, about $800 just to get into the ER. So it is about the money, but it's more about the impact that you're making on that person's life. What life changes are you making with that person? And there's been people that have utilized RAP, people that haven't, but there's been people that said, you know what, I'm really not interested in it right now where I am, but I'd love to take it. And that's the other thing too, is we tell them about the recovery center. If they're not from this area, we tell them about the virtual recovery center. But we don't just tell them about our stuff, we tell them about other stuff too, because that's the way we learn and grow, right?
That's phenomenal. I can't, data is such a tool. It can be such a powerful tool. And I think in the peer community, we've seen the harm that translating people into numbers. Like, we've seen the harm that causes, of being asked questions that are about someone else's goals or someone else's idea of what recovery looks like, and having the folks designing those questions or analyzing the data not be the people who answer, right? Like, being judged by external experts who very often, are representing sort of historically oppressive groups, we'll say, right? Like, there's a lot of not representation in research fields of who's part of those projects, who's understanding the information, who's translating that. And something in just listening to the questions that you asked, it's so brilliant, because these are questions that speak to, but they translate what the objectives of funders might be. We want reduced costs, we want health outcomes, we want this, but you ask the questions in a way that is centered on the personal peer experience, on someone's own wellness. So you're gathering data in a way that's respectful and thoughtful and holistic, right? Not, asking folks to share their satisfaction or to share what was valuable, but it also gives you stories that you can turn into numbers. And just your ability to rattle off, it costs this much for an ER, it's this much for hospital, this much for respite. Like, for folks who are motivated fiscally, right, or have to just be conscious of that, being able to being able to tell the story in many ways is so powerful. With that, there's kind of two questions that I want to ask. The first one is, in these conversations with MCOs, and I hear you talk about, it's not about a fee for service, it's about, finding funding for someone to be at the house for a day, or to have some sort of contract arrangement. And that's, I think, very creative. One question is, are you worried about pressures that might come from agreements with MCOs to ask different questions, to change your operations? So that's the first question. And actually, let's just go with that. Yeah, I mean, as transparent as you want to be about all that.
If you're not worried about the pressure, you're not doing it right. Yeah, I am definitely worried. I'm worried when my region said, hey, here's what we're going to do. We're going to throw in the middle of your contract, we want people's social security numbers, we want their date of births. And I'm like, no, no, not doing it. And, I stick to that gun because, these people need to have that privacy. Now, I understand there's certain things, but giving away a social security number is definitely far fetched. And I could see the MCOs doing that as well. They already do it with the community mental health centers that provide peer support. Just to throw that out there and give you an idea how Iowa is, if I work with you 10 hours out of that community mental health center as a peer specialist, 10 hours a month, that agency gets $150. If I work for you at that agency as a peer specialist and I work with that person for an hour, I'll get $150. That's a flat fee, $150. So what does that do? One, to the profession, but most of all, what does it do to that person and what you're trying to give out there, right? So yes, I am worried about maybe some pressures, especially when it becomes Iowa Medicaid enterprise being in the conversation, right? And that's the thing too. I know when I did talk to the first person in the mayor group, he said, we should be able to do this without having you have that high-tech military computer that you need. You're absolutely right. I don't need to go through that. People's lives are not valued by all that stuff, and it shouldn't be. We are doing it wrong if we are.
Phenomenal. Really, like, Todd, thank you, because you are so clear and about all the dynamics that are part of this puzzle, right? How do we find that solution through and stay true to the values of peer support and the reality? I think, folks, if you have other questions, specific questions, please feel free to throw them in the chat. Go for it.
One thing I want to say real quick is, I said I'm a person, and I am, and a person with a lived experience. And it's funny, through these last 5 months in dealing with, what are we doing? Are we going to be able to buy this house? Is the region giving us the money? I had a lot of meetings and a lot of phone calls with our attorney, and we paid him a lot of money to make sure it happens, which was ridiculous, to be honest. But he said to me, he goes, man, I could not do what you do. And this is an attorney. And I'm like, well, I couldn't do what you do. And some days, like you seen my respite house manager on the video, there's days I want to give up, but I fill my arm with tattoos. I try to be inspirational, and I can tell you right now, my respite house manager, when I say this, you annoy me with that, and that's fine, but I'm going to keep saying it, because one of the things that we can do is walk outside and look and count all the dark clouds, right? That's easy to do. The hard part is to find the sunshine and through all the darkness, and that cloud is our darkness, right? So there are times that I struggle. There's times that my house manager struggles. There's times that every single one of my house staff and beyond struggle. And one of the things that I do is I really do not practice what I preach sometimes. But sometimes it gets to the point where you have to. And that's the one thing I would say. And I remember back, like I said, the time when I said, I'm not going to stop it. I'm going to do what I said I would do. There's points where you're doing what you say you're going to do. You got to do some other stuff in between to take care of you, or else everybody else isn't going to be well.
That is such a powerful message, and I'm glad you're saying it. That we all have to, right, keep our own fires lit, keep our own wellness there, and that's what powers kind of everything else. I saw a question in the chat about why you decided not to buy the motel or the hotel, and I'm wondering if that connects with what you were just saying of taking care of your own wellness.
Exactly right. Thank you. You're not even here in Iowa and you know it, right? Through 2022 has just started for me, because January 1 till last week, when we actually moved into the house, was all about conflicts with, political leaders that said, yeah, I approve the grant, to the next month, they say it's too much money, right? So here's the piece. We would love to keep the motel. It's 13 rooms. That's 13 people that can be served that are living on the streets that want to move into recovery. And because they're homeless, they should not be discriminated against. They shouldn't. So we don't know what they went through to become homeless, right? So we wanted to use it as a long-term respite to support them people, to get them jobs, to get them Section 8, to get them housing, to get them out of where they are, because they might not be where they are soon if they keep staying the same way. But to be honest with you, the funding problem that I've had to go through with our respite house, the funding problem that I still have with our wellness recovery center, and I had to make a decision that, hey, I'm going to get what I need funded at that wellness center, or you're going to tell the people of this region that you're not going to care much more, right? And to have that motel, that would just be adding a layer of stress to myself. And I told my board, no matter what, because they wanted to do it, I said, no, I'm not doing it. And so they decided, yeah, let's sell it, right? I mean, it came with the property, but now's not the time. Now's not the time. Let's get through the MCOs. Let's get through these contracts. Let's get everything that we're doing now, not having to worry about it before we start something else.
It reminds me a lot of the importance of taking stock of what is happening now, not what I think might happen or could happen or but what is happening right now. Like, what's the reality of my energy, of my resources, of my partnerships? What's the step I can take today? And trusting that the step I take today will open up even more new possibilities I never thought were possible, right? Having some hope, having some faith that that there's so much more to come that we can't even see right now. And that if we keep moving forward in a positive direction, it's there. Todd, if I can ask, because you, I think I see a lot of faces like this is such valuable information, in the nitty gritty of it, in the big picture of it. But I remember when we were talking a little bit that you had a career in sales and in management before you moved into the recovery world. And so for the maybe last 5 minutes or so that we're together, could you talk a little bit about how you are using those skills in your job now? Because I think as we look at all of the different types of trainings of peer trainings that are available, a place where we could use more is about that management, administrative, sales, fundraising, like that piece of the puzzle. Could you talk about what your advice would be, or what you've noticed about how you're using these skills from your career now in your leadership position?
Yeah, so my career was many years in the rent-to-own, managing rent-to-own stores, and then the last 5 years, because I hurt my back and still tried to go because that's the way I was raised, right? And just to talk about that, that's a piece, right? I was raised, I didn't have a lot. My family was in poverty. I'd be made fun of at school and all these things, of what I would wear, how I would dress, all these things. And so when I got into rent to own, what I found was that, immediately I found that a lot of them were treating people like crap because they were coming to them and they thought they were better. And I got the mindset of, oh my gosh, these people are going through the same thing that I went through growing up. Treat them with respect, honor them. When people would come in, shake their hand, give them a hug. I can't tell you, even them working days in the rent to own where, they were used to that hug. They'd come in my office and give me a hug without me going out there. It got to the point where I had people that were working at the casino bring me in buffet tickets and all these other things, people bringing me in a shake. And you know why they did all that stuff? Not because I was begging. It's because I treated them like a person. It's that relationship building. And the thing that I found when I was going through a group and I became a peer specialist, I could never forget Carolyn Lang saying, Todd, would you like to share your story with others? I thought she was going to take me to like a church or something to just share, what I went through. I didn't know she actually was signing me up for the peer support training. And when I got there, how much of a life-altering experience that was. I'm like, oh my God, I've been doing this. I was doing it in my business, and that sales, that management. And one of the things is in the rent to own, you see a lot of people skip off with stuff. You see them not making the payment. But I'll tell you what, if you make a relationship with them, they're going to pay you first before they pay the utility company, because they'll feel guilty because they let their friend down, their relationship down, their connection down. And I think I just use a lot of that here now today.
Todd, thank you really so much for being here with us. I saw lots of cameras coming on. I see lots of thoughtful faces. You've given us a lot to think about, and I hope helped us focus some questions that we have about how can we create peer respite in Maryland? What are the ingredients? What's the order? What do we need to be thoughtful about? And I remember in the video at the top of the session, that your house is located in a rural area. And so thinking about the importance of understanding your community, what are the needs of the community? Who are the players? What are the resources available, and all of it. So I am 100% sure that we will have a list of folks asking if they can get in touch with you for some technical assistance. And I would just encourage everyone listening, if you're interested in coming together and really thinking through peer respite, like how could we make it happen? Please do contact us at voices@onourownnmd.org. I think there's a lot of interest. And now the question is how. It's how could we do it? How will we do it? So big round of applause, Todd. Thank you so much for your leadership, your passion, your inspiration. And we're looking forward to hopefully lots of chatting with you throughout the rest of the conference. Thank you, thank you, thank you.
Thank you.
Our mission is transformation. Through mental health or substance use challenges, we found our voice. With 30 years of experience in peer-run alternatives, person-centered training, and systems-level advocacy, we empower agents of change, lifting up leaders with lived experience to shape the future of healthcare. We are On Our Own of Maryland.